and I'm the communications lead. And I'm really, really pleased to welcome you all to our Lifting the Lid on Cancer in the LGBT community. Our host for the evening is Emma McAuley, who is Trekstock's first LGBTQ ambassador, and she came up with the idea of having this conversation about 9 months ago. So we're really, really pleased that we're able to do it today. Obviously, as I'm sure lots of you know, originally this was going to be a live event in London. In the current circumstances, we are holding it digitally. And we're still really hoping that we'll be able to hold the event as planned in the autumn, perhaps as a live event. And so what else do I need to tell you guys? If you look at the bottom of your screen, if you pull your little arrow cursor down, there's a box called Q&A. And so if you look in there, if you have any questions during the event, please feel free just to type them in there. I'll be manning that during the chat, and then I will give those questions over to Emma towards the end. The general format is going to be that we have about a 45-minute discussion, and then we are going to have 15 minutes questions at the end. As Emma was saying, obviously that's not enough time to have a chat about all the issues that we want to talk about today, but we wanted just to start the conversation and create a space to begin this conversation, and then we're going to continue it as much as we can going forward, hopefully at the live event in the autumn and in our community. I'm going to hand you over to Emma now, and I'm going to mute and remove myself from video so we don't have to look at me anymore. And but thank you so much for being here, and thank you so much to all our panelists, and I'm sure Emma's going to introduce them all now. Thank you again for coming.
Thanks, Tabitha. I hope everyone can hear me, but lovely intro there from Tabitha. I'm Emma, the first LGBTQ+ young adult ambassador with Trekstock. And I remember very clearly mentioning to Jemima about having this event whilst sat outside a bus stop at Whipps Cross Hospital. So very glam. Yep, we've got a wonderful panel with us this evening. Someone missing though is our lovely Brad. He's not very well at the moment, but hopefully he'll be able to join us at the live event once it happens in the autumn. And introduce us to our lovely panel. We've got Stewart, Claire, and Dr. Michael Brady. So I thought you guys introducing yourselves, just let us know about who you are, any of your pronouns, and why you wanted to be involved in this discussion. So should we start with Stewart?
Oh yeah. So yeah, that's me, Stewart. I use they, them, and I have CML, have been under treatment for about just over 3 years. Multiple different cities, and then didn't see enough LGBT support, so created my one in this Pan London. It provides peer support groups and information and education, and I just always like being able to lend a voice to these kinds of discussions to raise awareness.
Great stuff. Claire?
So my name's Claire Amaladoss, pronouns she and her. I had cancer as a teenager and now work at the Department of Health, where I'm the co-chair of the department's LGBT+ staff network. I work on prevention policy at the Department of Health and think a lot in that role about how we can address some inequalities, particularly in terms of screening.
Great. And Dr. Brady?
Hi. Michael is fine. Dr. Brady makes me feel really old.
Sorry.
No, that's fine. It's just a bit formal. Anyway, yeah, I'm Michael Brady. I'm the National Advisor for LGBT Health at NHS England. That's a newish post. I've been doing that for nearly a year. It's a part-time job. I'm also an HIV clinician. I do HIV and sexual health work at King's College Hospital in South London. So with the national job, the LGBT role, essentially I have a big brief to reduce health inequalities for LGBT plus individuals across health and social care, and that's really about improving experience, improving access, and improving outcomes. So I was really keen to join this meeting, or virtually, or as we were originally planning, face to face, because I think it's really important for my national work to connect with those with lived experience and those community organisations that are working to improve the experience. And as I'm sure we're going to discuss some more, there are particular issues related to cancer. So although I have a very broad brief, I'm doing lots of particular bits of work in specific areas, and cancer is one of those. So it's a real pleasure to be here.
Great stuff. Just before we get started, I said in an earlier email, just want to make sure that everyone is clear that when we talk about, even though we're talking about LGBTQ+, of course, our gender identity is different from our sexuality. Let's not get those mixed up, anyone who's listening in. And we might be talking about things that might bring back some memories that might be a bit upsetting for people. So just to remind you to seek support, speak to people. I know we were speaking just before we went live to everyone about collating a list of great places that people can go to for support. So hopefully that will be out there super soon. Okay, so I think starting with, of course, Stewart and Claire, who have lived experience. Do you feel like your identity has an impact on your experience of having cancer and your treatment, diagnosis?
Yeah, I'll go first if that's all right, Claire.
You go for it.
So yeah, I think so. My cancer's in my blood and in my bones, so I'm quite, I guess, fortunate in the way that it doesn't really affect my body in a gendered way, although it did make me, when you face your mortality, you kind of think about your identity in a different way, and you kind of address certain stuff. So it made me sort of come to terms with being non-binary and how I wanted to present that, and taking the pronouns that I felt more comfortable with. But the other way that it impacts my life is the fact that I don't have the usual support structures in my personal life that you can usually find in other patients or people. And that can be sometimes quite hard to translate into healthcare and share that with people, and then also personally manage. So, through my health, I've had to move countries, leave partners because of that. I lost my house because of it, because then I don't have the usual supports. It's all these extra things you have to deal as a nuance on top of actually going through the treatment. And then there's been other things where I've asked people to use certain pronouns and they just haven't. They say to your face they will, and then within 3 minutes they've forgotten. So it's navigating it as a whole process.
Okay, and Claire, what about you?
So I think certainly at the point at which I was diagnosed and had my treatment, it didn't seem such a big thing, and I think that was probably because I did not feel kind of sure and certain in my own identity at that time enough to kind of I don't know, I suppose expect anything different from the people that I was interacting with. So for me it's played out more since I have been out, and since I've been receiving kind of my late effect as a result of treatment and things like that. And certainly then it has been frustrating. There have been assumptions, and I'm sure we'll talk about it. Oh,
Sorry.
That's quite right. A bit later, but kind of endlessly introducing your partner and endlessly having them referred to as your friends is exhausting.
Okay, we did have like I at least had a kind of technical glitch there at the beginning part. But yeah, so Michael, are these the sort of things that are coming up repeatedly in terms of any research or when patient experience surveys are being completed?
Yeah, definitely. I mean, we do have a lot of patient experience surveys, particularly that talk about poorer experience of cancer care. Well, poorer experience of everything really for LGBT plus individuals, but certainly cancer care. And I think it's really telling. A couple of things that really struck me when Stewart and Claire were talking there. One was that the recognition that, you know, everybody's experience is different, you know, so we can't have a one-size-fits-all that just works for LGBT plus. And I think that's part of the thing that's going to, maybe I'm sure we'll get on to talk about this a bit later, about training and getting staff to have a better understanding. You know, I think so that's a really important thing, that you can't just have a single LGBT plus approach. You know, both Stewart and Claire's experience was different because of their different cancers or their different stages of life, or whether they were out or not. And, you know, and it also wasn't a static thing. You know, it's really interesting that Claire's experience has evolved and is different later than it was earlier. So I think that's something that people need to be really aware of. And those two things, I mean, it's such a common, and it should be a really simple thing. You know, the mispronouncing, and the you know, the not recognition that your partner may not be of an opposite gender. And what feels constantly to me so frustrating, because it should be so simple, but those are two really common things that come up time and time again. The lack of understanding about pronouns, and as Stewart even says, even after being told, you know, the lack of willingness to use them, and you know, having your partner assumed to be your sister or a friend. So I think it really just speaks really powerfully to just some of the key principles that we need to be putting into the workforce training around getting people, staff, cancer carers, and everyone to better understand what the experience is, and to understand the simple ways you can make it the experience a lot better.
Yeah, that seemed to be coming up a lot when I was like researching for our discussion, especially about the way that partners are being treated, and a lot was coming up about staff training. So I guess, like, if we said those kind of like two of our big issues would be how to help staff maybe, and as well how partners are treated, because, you know, whenever anyone has a healthcare issue, the support is so important and so key in helping us to get through whatever it is we're trying to deal with. And I was just wondering, I guess, well, Claire, I guess it would be different for you during your time of diagnosis and treatment, but so about being like out in your medical environment, because it took my cancer to make me address the fact that I wasn't straight, I was bi, you know, even where I've redressed my expression of feeling like I'm a woman, it's completely affected that. And it's that kind of now thing that I'm thinking about, do I tell my medical team? Do they need to know? Do I want them to know? So just, I guess really, that's kind of a question for me as well, but it's another thing that's been coming up throughout my reading. So I was just wondering about your experiences of whether or not being out, and what's helped or what's hindered that.
Well, I can speak to that because I've been out the whole time, but I think my experience of being out has been different all the way through the process, because in the beginning you kind of keep it as like an ancillary kind of like aspect of who you are, and you almost keep your sexuality to the side. So it's not that you're hiding it, but you're also not introducing it. But then also, because I'm under chronic healthcare, it does start to impact more, and you have to kind of share more of your life, and you kind of have to be a bit more kind of clear and transparent. But you're still always, like Claire said, you know, constantly having to go through that kind of stuff all the time, and constantly reintroduce who you are as a person or your partner. It can be really taxing. And every single time you do it, you're still making a cost-benefit analysis of, is this person safe to come out to? How are they going to use information? Is it actually impactful? Am I creating a roadblock if this person has a negative attitude towards myself? Like, have I made my treatment more difficult? So I personally feel as well, the higher up you go the ladder with your treatment as well, so getting to a specialist, you have less time with them anyway. So you tend to kind of rest on your CNSs or your nurses and kind of get the feedback from them, which generally has been positive. But there's also been times where people may not have been expressly homophobic, but it's the lack of knowledge which leads to a lack of confidence in discussing or accommodating you that can feel quite isolating when you come out and there's a frozen kind of response. Or obviously when you go to a ward and you see there's absolutely no leaflets that show your lifestyle.
Yeah, no, that's definitely something that's been coming up, this whole idea of like a cost benefit like analysis and this, I guess people looking for visual cues of, is this a safe place for me to be open? What would you say would be some of those cues to you to say that, okay, I'm safe here, or that maybe this is not the best place or the best time even for me to be out and open?
I mean, I think clearly things like rainbow badges really help. And it was interesting. I mean, in a similar respect, we introduced rainbow lanyards in my workplace, and thought a lot about who we gave those to and the responsibility they have when wearing them and the message that they're sending out. And we're really trying to avoid a scenario where actually, because they're wearing that, someone thinks they're really approachable, and then they approach them and they don't get a good response, or equally they're wearing it and they say something homophobic, and it completely clashes. And suppose also something like the NHS rainbow badges are fantastic at providing that signal, but I think it is important how you balance that with people really understanding, I suppose, what comes with wearing that, and it not being a kind of tokenistic thing, and has to kind of go side by side with the training. But I think what Stewart was saying about the cost benefit analysis is definitely so right. It's just that it's always that little kind of calculation in your mind, and that is influenced by your other life experiences. So I think, I've come from a faith background where there has been homophobia, and therefore I'm kind of thinking, well, I know that some of those people also work in the NHS, and so it's kind of, you just don't know what other people's personal convictions might be, and it does always feel a risk.
To add to that, actually, there's like research that talks about this idea of visibility, and obviously having positive visibility encourages disclosure and engagement, but at the same time people will sometimes look for other cues like religious materials inside a GP surgery or something like that, and that can become a barrier because you do assume that people have different values. So I think it's being mindful about not just displaying stuff, but also what are you already showing, and is it actually inclusive to everybody?
No, that's a great point, actually, about what else is being shown alongside it, and making sure that things aren't tokenistic, because it's in the same line of discussion as don't just stick a rainbow on something because it's June, because it's Pride Month or something like that. And of course, we have the NHS rainbow badge, rainbow pin that in the NHS at the moment. Brad, who was meant to be here, is would you say like a carrier of one? He has one. He's been awarded one.
I've got one as well, yeah.
Oh, well done. Great stuff, Stuart. So, Michael, has there been, in terms of in the cancer world at least, an impact already felt from that, would you say?
From the rainbow badges? Well, I think you could probably at least measure some of the impact just on the size of it. It's the Rainbow Badge project. So it's only just over a year old, and it's in nearly 70% of hospital trusts, which I think it's hundreds of thousands of staff that have signed up for it. I think that Claire's point about it's not just about signing up for it, it's not just about wearing it, you've got to live it as well, and it's got to mean something. But I think it's really heartwarming that it's rocketed, and that people have really embraced it. And there is an element of pledge to it. You don't get one unless you've pledged that you will be an ally and supportive and somebody that people can come to and open and and listening and signposting to other support. So I think the badge is a real success. I'm really keen to work with the Rainbow Badge team actually and take it to the next level, and that's something I'd really like to do nationally if I can find some money to do that. Yeah, I haven't got any money.
Yeah.
Do something I think even more powerful, you know, something where what I'm kind of thinking, I don't know if you know about the LGBT Foundation's Pride in Practice project, where they go into GP practices and support the practice to be more diverse and inclusive, and there's a kind of a rating system, you know, you get awarded a gold, silver or bronze, and you know, everybody likes a little bit of competition. So I'd really like to support the Rainbow Badge project to develop in that kind of thing, you know, so actually both individuals and organizations will be able to demonstrate, you know, what they're doing, whether it's about asking questions and monitoring, or whether it's about, you know, really delivering properly inclusive training, or whether it's about that visibility thing. Because I do think that visibility thing, just to go back a step, is so important. You know, the discussion about visible cues. The other thing I think is really powerful coming out of the Pride in Practice thing, and I'm sure it's going to be exactly the same whatever setting is that people, individuals, LGBT individuals, report that their clinical interaction, you know, how they feel the consultation with their GP was much better when they saw a rainbow badge, or a rainbow lanyard, or a poster in the waiting room for an LGBT charity, or, you know, something, or a same-sex couple on the website. You know, I think, you know, those visibility things are so important and relatively easy to do. You know, it's about making sure the language on the leaflets and the websites are not binary in terms of gender. It's making sure that there is an image of, or images of, same-sex couples or trans and non-binary individuals. So I think all of that stuff, all of those approaches, they feel like just little things, but they make a massive difference. You know, you know, I think, you know, the majority of people that go through the GP surgery is probably not going to notice it, but for the few percent of LGBT plus that see that, it makes a huge difference and makes them feel safer, better engaged and more comfortable, which makes their clinical outcome better, irrespective of what they've gone to see the clinician for.
So to add to that about other people not seeing it, I actually delivered some training last week and encouraged this cancer service to put rainbow flags on their notice boards, so people entering their area would know that they could come and speak to them, and pointed out that we are kind of conditioned to go look for these things so we understand we're safe. And everybody at the table who obviously didn't identify in our community had never seen one before in their lives at all, at any point, had never noticed one. And they were quite flabbergasted. There was this like underwritten code that we're using. so it just kind of shows that all this fear is kind of unwarranted, because people just don't notice. If it's not for them, they don't notice. But for people who do, it's so vital.
Yeah, true. I think that we said a couple of times there about like visibility. Of course, so Michael, your role's been, is it just over a year you've been in this role?
Nearly a year. I started in April last year, so nearly a year, yeah.
Oh, okay. And just thinking about the impact of having a national LGBTQ health advisor, that for me at least, it shows an importance and a recognition, at least, that there's different health needs and there's different health issues that come with being LGBTQ plus. And something that I was wondering was, would you say maybe we need something like that within more like the cancer world, maybe? Because of course you're one person and you've got the whole of health to be dealing with. I guess it would help you as well if there was someone.
Yeah, I mean, it would definitely be great if there were more of us, or if I had a big team and a budget. But anyway, that's a separate issue. Yeah, I mean, I think right. The scale of the issues and the problems is huge. So it does need more of us working on it. I mean, I do take heart from the fact that, you know, this post was created. I think it demonstrates a degree of commitment from the government and from the NHS to start to address the issues. I do think that, you know, things are shifting. You know, there's plenty of problems and there's plenty more that we need to do. But I mean, I've certainly found in the last 6 or 12 months that generally I've been knocking on open doors when I've been trying to go and talk to people about LGBT issues across the whole of the health service. So I think, you know, the environment is changing, and it may not feel like it sometimes, you know, certainly from, you know, individuals' experience or reading, you know, the Daily Mail, it must feel like we're all getting battered all of the time. But I think it's, you know, there's a positivity around, and it's really timely that this role's being created. I think, I don't know whether we need someone specifically working in cancer, maybe. I mean, I think there's always a little bit of a balance about, I think, not making it over, I'm going to maybe slightly talk myself out of a job now, but about overly specialist, because this is everybody's job. Equality is everybody's job. Addressing health inequalities is everybody's job. Being aware of LGBT health inequalities and addressing them is everybody's job. So whilst I think we need people driving the agenda, and more of us driving the agenda, I wouldn't want to see a situation where you create lots of little specialists and then nobody else working in cancer then feels that it's their job, oh, I don't need to do that because there's the cancer LGBT person. And so it's a bit of a balance, I think, about having someone with the responsibility and some authority to drive things along, but also making sure that everybody else doesn't step back from their responsibilities and leave it for somebody else to deal with.
Yeah, I think that's a really great point you've brought up there. And I've had the 20 minutes message through from Tabitha, so just making sure that the most important things we cover. I think I definitely, because we said about partners at the beginning, the support network, definitely want to bring it back around to that. So Claire, you were saying as well about how your wife is just, they just keep not addressing her, I guess.
And I wish I could say that it was it was a broader continuity of care issue, because I know that in my work we talk a lot about people having to tell their story more than once because they're seeing a different consultant or whatever. But actually in this case it is this, it's the same consultant. I see them every 3 months. I walk in, I introduce Lucy, previously as my partner, now as my wife. We got married 6 or 7 months ago.
Congratulations.
Thank you. And she's my doctor behaves, doesn't really acknowledge her. But what kind of annoys me is in the letter that goes every 3 months to my GP to say she's seen me, every single time that starts with Claire attended with her friend. And it's kind of, and because you know that you're going to see the person again in 3 months, I do feel cautious and funny about making a big thing about it in a way that I probably wouldn't in an anonymous feedback survey. And indeed, I remember, filling in the survey that led to the government LGBT strategy and ultimately to Michael's appointment. I remember writing it in my response to that survey and feeling fine about doing that. But I would never actually face to face with this doctor say, do you know what, it's really starting to wind me up that every time you write in this letter. So I guess, there are barriers, aren't there, in how confident we feel. And I think, gosh, I work in the Department of Health. I sit down with Matt Hancock once a week. It's mad that I don't have the the courage and the guts to say, can you please just call my wife, but I don't. And that's kind of the reality.
I think that's a really good thing to add about the fact that even by being people on this panel with our faces attached to it and everything like that, we're in quite a privileged position where we are able to, because of our life and choices, but also have got to that point. And there's so many people in the system that aren't able to come forward or ask for specific help or go through experiences like you have there. And I think there's also another thing is, as a patient, there's that kind of balance of power that sometimes gets forgotten about, where you don't want to cause a fractious relationship with your healthcare provider. But I think it's up to also healthcare providers between themselves to start checking on each other and what they're actually doing and how they're treating patients. Because as a patient, it's really hard to bring up microaggressions into the power system or take stuff forwards, because if you can't pinpoint it, it's really hard to validate. So as a patient, you can end up feeling kind of lost. And like you said, you just don't want to bring it up.
Yeah, it's a really good point about the power dynamics. I know even with other things, sometimes I felt that dynamic as well myself. Do you feel like maybe that is the power dynamic that would stop you from saying, actually, this is my wife, please address her as my wife? Or is it a bit more of that, will this affect my care?
I don't know, and clearly a rational part of me thinks this will have no bearing whatsoever on the care that I receive, but there must also be an irrational bit of me that kind of factors that in my cost benefit analysis.
I guess some of this also relates back to training that we spoke about at the start. Because at the moment, as far as I'm aware, from doctors at least, it's a non-compulsory, LGBTQ plus is non-compulsory part of their medical training. What is there any, I'm guessing there is something in the pipeline to help our professionals so that they are confident enough to speak about these, pardon me, about, you know, some of the issues that we face, whether it's about the fact that our biological families might not be on our next of kin. So, Michael, is there, what is in the pipeline? Is there anything we've got to look forward to, I guess?
I think, you know, the education and training stuff is so important, and we need to do a lot. I mean, I don't want to, well, to be honest with you, there is practically nothing, I would say, in medical schools, if anything. So, you know, compulsory or otherwise. Certainly not anything that's of high quality and consistently applied. There's like everything, there's pockets of good practice. So I know that Manchester University Medical School are doing some work with the LGBT Foundation, Cardiff doing some work with Stonewall. I know there's some work going on at Liverpool. So there's some little pockets, but I think if you looked across all of medical schools, you know, looked at the training of all the doctors of the future, there's practically nothing at all, I would say. So it's bad. And, you know, and I think you'd still see lots of examples where, you know, when there are scenarios in exams, or, you know, when we do sort of practical examinations and we get patients in that just kind of reinforce stereotypes. You know, it's the gay man with the HIV, you know, it's not a trans woman that happens to have sprained her ankle. You know, there's not a normalized aspect to it, and there's probably actually no trans or non-binary individuals in the exams at all. So there's a huge amount to do, and it needs to be done in a meaningful way. You know, there's probably little bits of pockets about equality and diversity, probably in GP training, because they kind of maybe think they're a little bit more touchy-feely and a bit more holistic, but not in a really, as we can see, you know, that we're still churning out doctors who keep calling Claire's wife her friend, you know, and it's thoughtlessness, you know. When I generally there are homophobic and transphobic medical.
I don't think that is that here. Yeah.
No, that's not that. No, I'm not. That's what I'm saying. You know, there are a few, but generally they're just thoughtless, and just, you know, I'm not caring, which is why I completely get, and it just really saddens me that people, and I completely get it, and I'm not going to say you've got to do anything different, but why people don't feel that they can challenge it. You know, it's really that power thing. We're here all in positions of authority and confidence perhaps in our work, but when you become a patient, that all just kind of goes out the door. And but I bet if there was some way to communicate it to that doctor, she'd be mortified and you know, would learn. But it's not your job to teach her. You know, it's the system's job to teach her. So the training. So I'm babbling on now, and I know there's not much time. So training is really important, and that is going to be a real focus of the work that I'm doing next year, the second year in post, because the system's complicated. There's a lot of people who have responsibility, or big organisations, medical schools, the General Medical Council, the Royal Colleges, who all have got responsibility for setting the curriculum, to deciding what training should happen, and for monitoring how good it is. But you know, even though it's a bit complicated, it's quite clear who should do what. And I think, as I said, there's lots of really areas of good practice. So we'll be doing a lot of focus on taking that good practice and forcing everybody else to do it.
I like that as well. We're forcing everyone else to do it.
It's all about the stick with me, no carrot.
So, like, in terms of like the training as well, what do we think? Do we think that this needs to start right at university when we're training our doctors, and how can we, I guess, carry this into once they've graduated and they're in their posts and working at the hospitals or wherever?
I'll just go briefly, and I won't hog the talking. I mean, it has to start right at the beginning, and it has to thread all the way through. So you have to start it with medical school, but there are lots of opportunities. I mean, our training is very structured, and our training is very, doctors and nurses and other healthcare professionals, is very competence based. And so actually it's not difficult, at each point where there's an assessment or an appraisal or an exam, to weave some LGBT stuff in. You see it happening with other things, that ethnicity gets more of a focus, disability gets more of a focus. So I think it's just about taking that broader approach to equality and applying it more so to LGBT. So, the opportunities to do it are relatively clear cut. We just need to put the content in there.
Yeah. I guess as well, maybe some of those small actions we spoke about, like just like displaying the little rainbow on the notice board, like you said about Stewart, things like that, put them into the training, because those are the things that we see, I guess. I've had my we've got like 10 minutes. So I know we've only got 10 minutes, but I think it is important to give mention, of course, to very marginalised group at the moment within LGBT, the LGBTQ plus community, are trans siblings and gender non-conforming individuals. You said about being like your pronouns not being used correctly, Stewart. What kind of effect does that have on you?
I think kind of similar to what Claire was talking about, in the sense of when you take it upon yourself to out yourself in any way, bring a partner into the room, or you make an effort to tell someone pronouns and stuff. And then for the example that's coming to mind for me, I told someone, like, are you up to date with pronouns? Because I was about to go speak at a board of directors, and they were just like, yeah. And I was like, okay, great. Can you just use they, them? And that would be really wonderful. Thanks. And then as soon as we go into the meeting room, this is Stewart, and he's doing all this work and he's doing all that. And you just kind of instantly do this thing like, well, why do I bother? Why do I expose myself in this and make this effort if you can't remember it within a 5-minute window? And and it's this thing, the best parallel for people that don't understand what it's like to be mispronounced, the best parallel I can make is when you tell someone your name and they purposefully mispronounce it. And if you correct them and they continue to mispronounce it, it's this thing of, it's just like, I shouldn't have to keep checking you. And this is the real point about pronouns. You should respect someone's pronouns even when they're not present. Like it's the person, it's their identity. It's not just to please them in the moment. It's a permanent construct. So it's a lot of that, but then again, obviously with people that are, for example, transgender, especially in that kind of binary sense of transgender, it's so much more impactful as well. And I think it's really important to make sure as well that doesn't become a barrier for people accessing services where they feel that they're not able to attend screening, and it puts them at risk. And especially if they're trying to disclose, and especially if a person has got a new NHS number and they need to tell somebody about their previous medical histories, but they can't because they're already being mispronounced. It's just, there's a real cumulative effect of it.
No, definitely. Just quickly before I carry on, we do have 10 minutes left, everyone who's in listening, and of course you can type your questions into the Q&A box, and Tabitha has also told me that you can type any questions privately by just messaging her, so I wanted to mention that before I forget. Good old menopause brain there, we'll do that. But yeah, because when I've been doing a lot of reading and preparing, most of the studies, they are prefaced with the title says LGBT, but they then preface with, but we didn't get many trans or gender non-conforming individuals.
Yeah.
And I got to the point where I kind of was smashing my laptop, my iPad against my head. It's like, well, I'm trying to do something here, and it's getting in the way. Like, so I guess really what it is it a case of people not being included, or is it a case of people not wanting to come forward? Maybe some of those fears we were speaking about, extra compounded by by the still blatant discrimination against people based on their gender identity.
Yeah, so one thing that I noticed from people that I've met at stakeholder events is I've met certain trans people that won't correctly respond on like a feedback form because it outs themselves to do so, and then they feel like they've been sort of picked out of the room. But also in data, you know, usually it's better to find data that is trans-specific, because otherwise if they do try and lump together this LGBT thing, then you do obviously miss out some kind of real nuances of data. And that even goes for other hidden minorities. So bisexual people coming out to the healthcare providers, the rate that don't do it is so much higher than general lesbian gay numbers. But if you put them all together, you miss that effect. So it's making sure that when you do look at the data and you look at the number and all this kind of stuff, you do see, like you said, who are they really looking at, and can they really speak to that experience, or do we need more information in that sector? You know, is that not the full story?
No, definitely. So I guess thinking about that, then how can we support people to make sure that they can come forward and be part of research, or even just to make sure they're getting the support that they need, without necessarily outing individuals, whether that be, I guess, whether that be their gender identity or their sexuality. Because that was one of the things during this talk I was very concerned about, was making sure that people who aren't out can still get that support from what we're discussing. So I was just wondering, any thoughts on that, about making sure that we can collect that data and that research?
I think from the small bits I've done in setting up peer support and also doing a couple of bits of research and education, the thing is getting people to trust what you're doing with it, and that you're a trustworthy person and they know what it's for. Because I think as well, a lot of people feel tokenized and feel they just get their patient story taken and put on a brochure or whatever, but there's never anything that really comes out of it that helps the community. And also there's the trauma of having to repeat your experiences. So you have to really weigh that up and make sure that people understand the importance of it, where it's going, what the aims of things are, and whether that comes from demonstrating your ability to support people in general, or whether it comes to partnering with other third sectors that are doing a great job already, so that you have that kind of safeguarding and oversight, so people can trust that you have the right intentions and they're going to get the correct support or representation that they're looking for.
Yeah. When you say like those third parties, what sort of people are we talking about here? Because there might be people who are wondering, so that they can improve their practice as well.
Sure. I mean, obviously you've got like LGBT Foundation and things they're doing with Pride in Practice and stuff like that, and the other stuff they do. Even, you know, people like Stonewall, but there's also other more community-based ones, especially in London. So my friends down there, Outside Project, and helping people with crisis and homelessness, is making sure that you're getting into the community rather than speaking for the community.
Can I just quickly add on that? Absolutely, 100%.
Of course.
I mean, in the sense that I tell people in the NHS this all the time, you know, that you have to deliver services and develop services in partnership with those with lived experience in the community. So just a brief example, I run a sexual health clinic for trans and non-binary people at our clinic at King's, which we do in partnership with Clinic Q, which are a really amazing organisation working with and supporting trans and non-binary individuals. And it's been massively popular from the first day that we opened, and that's because it's been delivered with Clinic Q. So there's instantly a level of understanding and trust from the community. I think if I just set up a sexual health clinic and said, here's our sexual health clinic for trans people, you know, it wouldn't have the same level of popularity, or it would take a lot longer for people to feel confident. Because, you know, we need, however, I say this to healthcare professions all the time, however good you think you are, you have to remember that people are really wary. You know, people have been discriminated against, people have had poor experience. It's all over the place. So even if that's not you, they're going to expect that from you, or they're going to bring that previous experience with them. And delivering with, you don't, even if it's just having someone else's logo on your website or on your leaflet, just saying that I've recognised and heard from the community in the delivery of this service makes a massive difference, I think.
No, I think that across for people who have been affected by cancer, there is that element of trust in knowing that there are people who understand what you've been through, who are helping to provide services, and who have helped provide services. That's what I meant. Okay, Tabitha has just told me that we are rolling into our little Q&A section. She's got us some questions. Tabitha, I don't know if you're going to come pop back in, or if you're sending them to me, or sorry. Okay. Okay, so we've got one here. So it says, should we ask about sexuality/identity at the first visit, or wait to be told? I guess that means asked. I assume some people would love to be asked and some would find it awkward. So anyone who wants to jump in with that one.
I would just say kind of what we were saying a moment ago about making sure people understand why they're being asked and what it's used for. And I think the other thing with disclosure is making sure people understand where that information is going. So if they go to their GP, is it just kept at the GP? Is it kept to the PCN, or is it going into the full system? Because there's costs, but there's pluses and minuses. The plus could be that if you trust the system, you won't have to come out to every single new healthcare provider. But at the same time, if you are untrusting or you had negative experiences, maybe you just trust your GP with that information. So it's difficult to know, but the important thing is as well is teaching the community that there is a real impact of that data, because I think a lot of people in the community don't know that we have poorer health outcomes across the board. So if they were more inclined to know that, they'd probably be more likely to disclose so that they can get more appropriate healthcare.
Okay, and I guess if that question was asked from a healthcare professional perspective about should what they should be doing, what would we advise from what advice would we give to a healthcare professional then?
About asking the questions, you mean?
Yeah, because we think that question has come from a healthcare professional. Right.
So asking questions, sexual orientation, gender identity, trans status, monitoring, a mouthful. That's what I spend probably most of my time doing. I just think, it's so important that we get to a position where we are comfortably and appropriately asking about sexual orientation, gender identity, and trans status. Just because, and in the same way that we do about postcode, and we ask that really to understand about deprivation and poverty. We ask about ethnicity. We ask about date of birth for age, because there are health inequalities for all of those things. So until we get much better at asking all of these questions, we'll never really understand the breadth and the depth of the inequalities, and we'll never really be able to do anything about it. Stuart's absolutely 100% right, but that has to be in the context of assuring people about the security of that information and how and by whom that information will be used. Where we do start to ask questions about sexual orientation or gender identity, the second after heterosexual, the second biggest category is prefer not to say, because people don't feel comfortable about giving that information. I also kind of think that, we talked about the visibility thing earlier. There is an inclusivity about asking the question as well. It's not just about collecting data for the system. If you're non-binary, or if you're a trans man and you go to register at a GP or to check in at A&E, and you're offered a form that only has two options, neither of which is you, then before you've even got in there, you're excluded. Before you even get in there, that service is saying to you, we don't recognize you, we don't understand your experience. You are probably reasonable to be fearful that somebody might be mean to you about your gender or sexual orientation. So there is an inclusivity for the individual to see their gender identity recognised on a registration form. So I think it's super, super important. I think it also it's part of the training thing. It gets people thinking about it. It gets people being aware about it. And that's about the staff thing. Before we do this more widely, we have to make everybody understand why. It's to make your experience better as a member of the community, and for staff, it's about being able to deliver better care. So it has to be part of a broader training so people understand about why and how to ask the questions. So I think it's really important.
Great stuff. Not necessarily a question, but a topic that's being asked about is fertility, about whether there are any differences in terms of the options given, or even if there is the discussion had once somebody is out in their healthcare team. Has anyone here had any experience in terms of fertility, I guess, preservation, or having those questions asked?
Yeah, For me, when I went on treatment, my treatment's for life, and I was told that whilst I'm on treatment, I can't have kids. And I was told with no kind of warning, pre-warning or anything like that, about that we were going to discuss it. It just kind of came up, and it was a 5-minute conversation. I had to make a decision on the spot. I was also in another country at the time, and it was the difficulty of that decision on top of my sexuality and that's already quite difficult, obviously, being someone that sleeps with men and then choosing to have a child. So when I compounded those two, it kind of almost felt like I negated the option, and I didn't really have an option to discuss how that could work, or that intersection. So yeah, for me, it created like an extra barrier that I wasn't really given the time to really go into.
What about you, Claire? I know that obviously being diagnosed as a teenager, that can also, the differences in ages can affect what you're told about fertility.
Yeah. And I think about it a lot, actually, and how different it would have been had I been older and been out, and what that conversation would have looked like with medical professionals, with my parents, whatever. So it wasn't an issue for me, given the age that I was, and where I was in being out. And so I did have open conversations with my consultants about it at the time, but I do think that would be much more complicated now.
Okay. And so we also had the question about whether we know how many young adults that are LGBTQ plus have been diagnosed or are living with cancer, and are there any types of cancers that are particularly prevalent or we're high risk of? Do we have those numbers?
I don't know if we have them in the case of incidents with an age component, but there's definitely a lot of data around higher incidence and risks. So there's quite a lot, but you have things like breast cancer issues in women that sleep with women. A lot of the issues actually come around not being able to disclose and then having later diagnoses and stuff like that. But there's other things like HPV and the risk of cancer. So people give them misinformation until they don't need a cervical smear if they sleep with women, which is obviously incorrect. And then also even with men and anal cancer and risk of HPV transmission, people not being aware of it. So yeah, there's definitely some higher incidence data, and I'm sort of working more on getting some of that information out there. But when it comes to then pulling it down by age, it's quite difficult because there's not enough data overall, and it's quite hard to get it.
Yeah, I guess it's that we're looking for two different areas then. One that already is having issues with data collection itself. There will be difficulties in figuring out in terms of age as well. Claire, you were saying as well that in your work you're doing things about addressing the inequalities in screenings.
Exactly. And so I mean that's across all of the different protected characteristics that Michael's been talking about, but we do understand that there are whole groups of the population that aren't taking up screening opportunities in the same way, and that is really disproportionate for some LGBT communities. And I mean, I've experienced that in terms of my interaction with cervical screening as well. And I think I was looking up the statistics before our chat today, but there was quite a big study in the northwest of England that found basically nearly 40% of lesbian and bisexual women were told at some point that they didn't need a test because of their sexual orientation, and in many instances that was from a healthcare professional. So that there is a lot to be done clearly in terms of addressing those misconceptions and targeting our communication channels to do that appropriately. And then I think there are, when we're looking at kind of formal screening programs, one of the ones I'm working on at the moment is the NHS Health Check, which is for people in midlife, so a bit later than the age group we're talking about now. But again, you know, thinking about what are the modules and components you have in the kind, almost the sort of conversation scripts that you're giving your GP, that would flag different things, and kind of lead a conversation that is much more personalised and tailored to that person in front of you.
While we're talking about this stuff, I quickly want to just mention some good practice. So the No Barriers project with 56T and Alison from the GIC and Joe's Trust, opening up cervical screening for anyone with a cervix. So it's open to non-binary, trans and women. So, you know, there are pockets of good work out there that will hopefully show effect and ripple through the community. But, you know, if you're facing these issues of feeling that you can't go and get that testing done, like there are options.
Absolutely.
Yeah, I noticed as well the Eva pill, they seem to be a lot more mindful of their language they've been using, and as well Copperfield, in terms of breast cancer awareness, they've been using the line like girls, guys, and non-binary pals, and making, I know that in one of their campaign videos they made sure they really worked hard to make it quite diverse. I guess because, you know, we're part of community, we've got lived experiences, and we're very much in the hospital settings as either patients or working in there. What services would you recommend, or would you like to see coming from either this talk or another one, or even just what do you feel would be the best place to start? I know it's a big question.
The thing, so I'm quite new to all this stuff. I'll be very honest, I'm quite naive. I've only really been actively involved in it. Yeah, I've only really been actively involved since last summer. And one of the things that I always try and do with the work I do, so in supporting LGBT people with cancer by providing peer support and other stuff, but the other thing I always try and do is pull everyone together. Like Michael said earlier, it's knocking on open doors. Everyone's ready for it, but no one's has the time, funding, or ability to take the initiative. So if it's about pulling people together where possible, and make sure that people understand there's like a unanimous consensus towards inclusion. So, and I think through that teamwork, you can kind of show not only there's extra resources available, but show within the community that there's other ways to support people through diagnosis, social prescribing, other ways to create personalised care.
Mm-hmm. Claire, Michael, would you want to add anything onto that?
I think there's something really just about creating space for conversation and for people to ask questions that often they feel embarrassed about asking. And I mean, we run a series of workshops within the department, particularly with the private offices. Oh, hello, little dog. About the language that they use interacting with ministers and parliament and everything else, and those constituencies. And one of the things we do is put up a whole series of phrases and questions and things that people might say, and all of those, I think, to this panel, for each of them we'd be able to say, oh, that's inappropriate because, or that would offend me because of X, or da da da. But usually most people say, oh, most of them seem okay things for me to say. And so I think it's just about creating a space where they're not terrified of causing offence, because as Michael was saying earlier, like, you know, the vast majority of people aren't out there to be malicious or anything like that, but are scared to ask about what is okay and what isn't. So I think trying to open that up and say, actually, almost for the next 20 minutes or so when we have this conversation, don't hold back. I'm not gonna feel offended, you know, ask what you want to ask, and then based on what I say, please don't say these things again or whatever, is really important.
Okay, great. And I guess sort of like as a last question, the question I wanted to ask anyway, but one that's come in quite a few times is, what can individuals do for the for us, for LGBTQ plus people affected by cancer, which I know again is a huge question, but I think it's in terms of people thinking, what are the small things that I can do as an individual that will help you?
I would say educate and advocate. So if you're unsure, go and look. There's actually some data out there. Stonewall does really good health reports. So if you just wanted to know why it's an issue, take a quick look at them. They're really wonderful. And then when you have that knowledge, when you see someone struggling to access the system, or you have a friend that hasn't been screened and you feel they should, or all this kind of stuff, push them to do it, advocate for it, help them go through the process, go with them if they need to. And if you're a healthcare provider and you see a patient that's struggling to get through the pathway or access the correct stuff, find ways that you can help them. Like this thing I'm always pushing is active allyship. Like allyship isn't a passive mode of just being okay with someone. It's going above and beyond to make sure that you're addressing those inequalities. And a good way to check if you're doing it right was the last time someone identified you as an ally or said thank you for your help.
Yeah, I think that's a pardon me, a great way of saying that. The last time that somebody thanked you or described you as being an ally. What about you, Claire? What do you think?
Yeah, I mean, I think probably my biggest thing would be about giving people permission to ask questions. So I'm conscious I spoke last time. I'll let Michael.
Michael?
I mean, for me, it's something about the little changes that you as an individual can make to change the culture around you. It's a bit about what Stewart was saying about educating yourself. I mean, I think, and then it goes back to what I was saying before about the casual thoughtlessness, which is just you're not empathizing. You're not putting yourself in somebody else's shoes. We don't have to have shared an experience to treat somebody equally or with respect, but we have to be able to ask the right questions and be empathetic. So for me, there's something about, and that's also about reminding ourselves of our privilege and the assumptions that we make based on that. So this is slightly rambly because it doesn't really come back down to what a specific individual think people could do. I think it's really about just trying to be mindful of the impact of your actions. I mean, this is what I would say, are the words that you write in that discharge letter about Claire's friend. Be mindful and to put yourself into somebody else's shoes. If we can all do a little bit of that, and challenge as well. I think that's the other thing. So we let too much stuff go by. Somebody typed that letter. Somebody sees somebody making the joke in the corridor. I'm not sure if I really like the word microaggressions, because I think they're all just aggressions, but it's that daily stuff that other people see and acknowledge and just walk on by. So I think it's challenge as well.
Okay, yeah, challenging. Pardon me. Yeah, we are coming to the end of our time together, which makes me really sad, because I've really enjoyed meeting and seeing you all again. And I think if anything for people who are listening to take away from this is the importance of identity in a cancer experience, in a health experience, in terms of how diagnosis, treatment, and of course outcomes, and in recognizing that does influence how things go for us, and that if you do recognize those unique needs that we have, we can actually have those patient-centered, holistic care, make sure that is provided. For me, I hope that's what if that's one lesson, that's what we've given you. And that even, as an individual, you can make change through your actions as well. But I want to say, of course, big thank you to our lovely panelists, Stewart, Claire, Michael, for giving us your time this evening to come and have a chat and start this conversation. And of course, your patience in how it's moved from an actual real life setting to technology. Of course, thank you to everyone who's watching at home for listening, taking part. And of course, I want to say a huge thank you to Trekstock for not just saying, we'll do this one, but how enthusiastic you've been in your support. Like last week, there was so many tweets about the LGBT Women's Health Week,